Good morning, everybody. We're delighted today to have Dr. Emily Hinchcliff give us our Grand Round talk today. She is an assistant professor in gynecology and oncology at Northwestern. She received her medical degree from Harvard Medical School, where she stayed on to complete her residency training at Brigham and Women's Massachusetts General Hospital. She then completed a fellowship in gynecologic oncology at University of Texas, MD Anderson. And while she was there, she also received her master's in public health from the University of Texas School of Public Health. She has a concentration in clinical trial design and epidemiology. Her research interests include early phase clinical trials for gyn-onc malignancies with a particular focus on immunotherapy. She is also the associate program director for the OBGYN residency at Northwestern, reflecting her interest in medical education. Thank you, Dr. Hinchcliff.
Thank you so much for that introduction. Let me see if I can share my slides appropriately. Okay, so thank you all so much for the opportunity to speak this morning. I'm Emily Hinchcliff, one of the newest gyn-onc faculty here at Northwestern. I have no disclosures. In terms of the objectives for today's talk, I know that this is a relatively varied audience, so I've tried to include a little bit for everyone. First, I want to review endometrial cancer basics, some brief epidemiology, and then also really delve into the meat of the talk, which is to review the molecular staging and molecular-based prognostic algorithms. In doing so, I then want to talk about opportunities for molecularly directed adjuvant therapy, as well as consider targeted therapy options by molecular subgroup. So to orient everyone to why we should care about endometrial cancer, first, it is incredibly common. Almost 66,000 women will be diagnosed with endometrial cancer in 2022. Over 400,000 new cases arise globally, though that statistic is actually a little bit out of date and it's higher than that. Importantly, the rates of new uterine cancer are rising relatively rapidly as compared to other cancer types. That number is about 0.6% per year if you look between the years of 2010 and 2019, with death rates rising an average of about 1.7% per year for the same time frame. Importantly, I think the death rate from non-endometrioid tumors is rising even faster at about 2.7% each year. So to speak a bit further to that, classically endometrial cancer was grouped into two pathologic subtypes. Type 1 cancer was typically associated with good prognosis, while type 2 cancer was the poor prognostic group. To briefly review the characteristics of each of these, type 1 endometrial cancer is endometrioid in histology and generally low grade. Therefore, stage at diagnosis is usually early. The etiology is felt to be related to unopposed estrogen, so increasing rates may be associated with increasing rates of obesity, at least in part. From a pathologic standpoint, these tumors are often hormone receptor positive and have more common microsatellite instability, often P10 mutated. Conversely, type 2 cancers are felt to be the non-endometrioid types. So the aggressive subtypes such as serous, clear cell, undifferentiated, including carcinosarcoma, and therefore are usually high grade, and the stage at diagnosis is often advanced. These tumors are thought to be sporadic, tend to be hormone receptor negative, and many are P53 abnormal. However, these groupings of endometrial cancer are inherently a little bit clunky. The imprecise classification leads to issues not only with prognostication, but also with adjuvant therapy. Certainly, they're limited in their ability to risk stratify based on just kind of the general nature of these umbrella categories. Additionally, histotype and grade have been shown to be poorly reproducible. Studies demonstrate inter-observer agreement occurs in only about 60% of cases, and these inconsistencies not only impact kind of how we give adjuvant therapy, but also creates heterogeneity in the clinical trials that we've used to define adjuvant therapy best practice, so makes those results more difficult to interpret. Therefore, a significant amount of recent work has been done to move toward more molecular classification, and that's what I want to talk to you all about today. The 4 subgroups, as initially classified from the Cancer Genome Atlas, include POL-E, or ultra-mutated, microsatellite instability, or hypermutated, copy number low, tending to be that endometrioid group, and copy number high, or serous-like. Characterization into these groups was based on total mutation burden, as well as particular mutations such as P10 or P53. So let's delve a little bit further into these groups. Again, here are the 4 subtypes as defined through the TCGA. So the first group, POL-E mutant tumors, make up about 4 to 8% of endometrial cancer and are, as the name would suggest, characterized by mutations in the exonuclease domain of DNA polymerase E. Epsilon. They are characterized by very high mutational burden and have excellent prognosis with a 98% survival rate in the TCGA data. They tend to track with lower grade endometrioid tumors histologically, but have been found certainly in higher risk subtypes as well. Importantly, retrospective data suggests that there is a decreased recurrence risk in POL-E mutated cases, which certainly becomes relevant when we discuss potential modifications to adjuvant therapy strategies. So again, just to kind of go through some of the data, you see that the POL-E subgroup here in these various Kaplan-Meier curves really has a very, very low risk of recurrence. The second group we have is the MSI or MMR deficient tumors. I'll use those two terms somewhat interchangeably. These make up about 20 to 40% of all endometrial cancer. It is important, while I'll use the terms interchangeably, to sort of clarify the nuances of testing for determination of this category. MMR deficiency includes IHC for 4 proteins, including MLH1, MSH2, MSH6, and PMS2. MSI status, or microsatellite instability, is an assessment of the microsatellites and is determined by next-gen sequencing. Generally, these are concordant. There are very, very rare cases where they are not concordant. Importantly, this represents an intermediate prognostic group. While MSI high status certainly is a biomarker for immunotherapy, and we will talk about that more later in the talk, it may also portend possible chemo resistance. So again, as you see in these kind of Kaplan-Meier curves, the MMR deficient subgroup of endometrial cancer tends to be what we consider intermediate risk. Copy number high, also known as serous-like, represents the poorest prognostic group. They are characterized by frequent P53 mutations, and the vast majority of this subgroup, about 73%, are serous-like in the TCGA. We will discuss in much more detail the role of adjuvant therapy for this group, but these patients do seem to derive more benefit from chemotherapy in multiple different trials, including PORTEC as well as GOG86P. So we'll talk about those trials in a little bit more detail at length, as well as the trials of immunotherapy and combinatorial strategies. The biggest thing I think to note here is just that this group is a very, very poor prognostic group. The last group represents the copy number low group, also known as NSNP, or no specific molecular profile. This group makes up the remainder of endometrial cancer, approximately 40 to 50% overall, and again, represents an intermediate risk group. These tumors are often what we think of as endometrioid, hormone receptor positive, can have a significant amount of LVSI within this subgroup. Further work is being done to kind of further stratify, since this again represents a relatively large umbrella term. Investigations of Wnt and L1-CAM, which I'll talk about briefly in a moment. In terms of Wnt or CTNNB1, they make up about a quarter of the NSNP subgroup. They tend not to track with L1-CAM, but do have substantial LVSI. This high intermediate risk group has higher risk of distant recurrence. As you see, the hazard ratio of about 2.9. Therefore, potentially, this could represent further stratification of this copy number low group within, to try and select those patients who are going to do more poorly. Similarly, L1-CAM or L1 cell adhesion molecule, has been shown to be a strong indicator of high-risk disease. So L1-CAM does track with abnormal P53, making up upwards of 10% in the NSMP group and up to 80% of the copy number high group, which we just talked about. So while I'll show multiple other Kaplan-Meier curves indicating the prognostic ability of these molecular cohorts, I did just want to bring in within the NSMP group that you see here, the disease-specific survival was significantly worse for L1-CAM positive with a hazard ratio of near 8. Again, on the Kaplan-Meier curves, just to highlight the colors, the P53 wild type NSMP L1-CAM negative and the P53 wild type NSMP L1-CAM positive, you can see that that group does very poorly, almost tracking as poorly as the P53 abnormal. So how do these risk groups molecularly track with our classic histology? In some cases, these groups track pretty well, such as nearly all serous uterine cancer falls into this copy number high or P53 abnormal subgroup. Conversely, about 70% of those that are copy number high are serous. However, for other histologies, these pie graphs demonstrate significant heterogeneity in the molecular makeup. Excuse me. As you can see here, high-grade endometrial cancer is essentially evenly split between molecular subtypes, and even our most common garden variety endometrioid here, while much of it is the NSMP group, about a third is made up of these other molecular subgroups. This again speaks to kind of potential limitations of the pathologic subgroupings to truly predict tumor behavior and therefore prognosis. But do our molecular subgroups actually do better? I'll show some data that demonstrates improved prognostic predictive ability. First, this chart just looks at the frequency of these subgroups within GOG 210. GOG 210 was a surgical pathologic study to create basically a clinically annotated tissue biorepository for endometrial cancer. From 2003 to 2007, this was openly enrolled. And then from 2007 to 2011, eligibility was restricted to try and enrich the cohort for underrepresented patients and for those at higher risk. In this study, serous-like tumors made up about 8% of the cohort, but contributed about 19% of the cancer mortality. The NSMP was the most common and made up about 5% of cancer mortality. MSI high or deficient MMR was 39% and contributed just under 8% of mortality. And lastly, the Pol E group, making up only a small percentage, but again, doing incredibly well with very little contribution to overall mortality. So in clinical practice, how are these results and subgroupings being applied? This chart kind of represents our classic potential schema for the molecular classification of endometrial cancer using sequencing and IHC results to segregate patients into these molecular subtypes. So in 100 hypothetical patients with newly diagnosed endometrial cancer, first performing Pol E sequencing would reveal the approximately 5% that fall into the Pol E mutated group. Then we would do IHC for the MMR proteins, revealing the 25% in the MSI high subgroup. IHC could then be performed for P53 to better stratify those P53 abnormal, and then split the remainder of the cohort into copy number high and low. This molecular subtyping strategy, or PROMIS, proactive molecular risk classification in endometrial cancer, has now been applied and validated not only on TCGA samples, but multiple different cohorts of endometrial cancer. These Kaplan-Meier curves demonstrate progression-free survival for each subtype tracks consistently. Pol E, seen in blue, do incredibly well, as we've seen, while P53 abnormal in red do very poorly. The MMR deficient and the NSMP groups in orange and green respectively are again seen as intermediate risk and fall somewhere in the middle. In a separate cohort of 410 endometrial cancer seen at right, you again see the value demonstrated. This graph happens to be overall survival probability, slightly higher percentage of P53 abnormal than in the hypothetical group. You again see these patients do very poorly in dark blue compared to the Pol E patients in green, with an essentially flat line near 100% survival, and then the intermediate subgroups in the middle. It has also been interesting to return to our kind of large endometrial cancer trials and further delve into this molecular subtyping. To briefly recap, PORTEC 1 and 2 were trials of radiation for high intermediate risk endometrial cancer. PORTEC 1 included just over 700 patients who got surgery, notably without a nodal assessment, and with stage 1 disease, and included those with grade 1 greater than 50%, grade 2 any invasion, and grade 3 superficial invasion. So those in that high intermediate risk, with while those with sort of very high risk were excluded. These patients were randomized to external beam radiation versus observation. PORTEC 2 included over 400, again, stage 1 to 2 patients with high intermediate risk, randomized to brachytherapy versus external beam, a non-inferiority study for vaginal recurrence. In these trials, when the molecular subtype was determined, there was, as you might expect, significant heterogeneity in the population, as you see here. As you know, the prognosis for these molecular subgroups was again borne out, but I think more importantly than knowing the survival for these molecular subgroups is that this heterogeneity was included in the trial, and this trial was used to make key adjuvant therapy decisions. The same is true for PORTEC 3, which was a trial of just under 700 patients randomized to chemoradiation versus radiation alone in high-risk endometrial cancer. High risk was defined as grade 3 with deep invasion, 1 to 2, stage 2 to 3 endometrioid, and 1 to 3 serous or clear cell. This cohort, molecularly speaking, was highly varied, basically evenly split between the subgroups, with approximately, slightly fewer P53 abnormal and Pol E at about 13%. Again, the prognosis of each of the groups within the trial is remarkably similar based on molecular cohort for the 400 or so that had molecular subtyping, independent of treatment arm. So this brings us to how do we use this data to our advantage? We now know that the significant heterogeneity of the trials that drive our treatment decision makings, we want to use this data proactively. So PORTEC 4 is a randomized trial of molecular profile-based subgroup versus standard recommendations for adjuvant therapy in early stage endometrial cancer with a 2-to-1 randomization. So the standard treatment arm based on clinical pathologic features goes on to receive standard recommendation, brachytherapy, while the molecularly based treatment arm is characterized into favorable, intermediate, or unfavorable categories. As you see here, the experimental arm is determined by a molecularly integrated risk profile. Those with Pol E mutations are automatically favorable and go on to receive observation. Mismatch repair subgroup is inherently intermediate risk and receives brachytherapy. The NSMP or the MMR proficient non-Pol E mutated are further classified by Wnt, so wild type versus mutated. Those with wild type are deemed favorable for observation, while the mutated subset are deemed intermediate. And then lastly, those with P53 mutation, greater than 10% L1 CAM expression are deemed unfavorable and go on to receive external beam radiation. Interestingly, the only pathologic classification in this group is as well with those with significant LVSI are automatically deemed unfavorable regardless of molecular profile. This demonstrates the importance of this classification. Prior groupings are seen here in this Kaplan-Meier curve, high risk, low risk, high intermediate risk. However, within that high intermediate risk, making up a huge subset of patients, we can further stratify and demonstrate significant variability in prognosis, thereby again emphasizing the importance of teasing out the most appropriate adjuvant therapy for this group. A second study, TAPER, or Tailored Adjuvant Therapy in POLE mutated and P53 wild type early stage endometrial cancer. Again, as you see, surgically treated endometrial cancer, undergoing POLE mutation testing, as well as IHC for P53 and MMR. Those with P53 mutation were excluded in this trial, as this trial really seeks to determine if we can de-escalate adjuvant therapy for these patients. All patients with POLE mutation will be observed, regardless of histotype. While those within the NSMP group are then stratified partially based on molecular risk, including CTNNB1 mutation, and then partially based on pathology, as you see here. Those with very high-risk pathologic features, such as grade 3 or extensive LDSI, will be excluded and no de-escalation will be recommended. However, for those with intermediate or low-risk features, observation versus brachytherapy will be given. Lastly, it's important to point out that these molecular subgroups are relevant not only for early stage endometrial cancer or for this high intermediate risk disease that we've been talking about. Studies in more advanced endometrial cancers again demonstrate that these subgroups can assist in the determination of which patients derive the most benefit from chemotherapy. As you see here, similar to the other Kaplan-Meier curves I've shown you, POLE mutation patients do incredibly well, regardless of treatment choice. Conversely, P53 abnormal patients derive significant benefit with the addition of chemotherapy when compared to radiation alone, as seen obviously in the second curve here. The MMR deficient and NSMP groups again have intermediate prognosis and don't seem to have clear benefit from adjuvant therapy, but we suspect that some of that is that these represent a kind of, especially the NSMP group represents an umbrella group. Another study where this finding is borne out is GOG86P, which is the addition of bevacizumab to classic platinum-based chemotherapy doublet. In those with P53 mutation, pulled out on the sort of Kaplan-Meier curve to the right here, there was a significant improvement in progression-free survival seen when chemotherapy plus bevacizumab was given. These discussions therefore lead us into the world of targeted therapy. How can we better tailor our treatments for endometrial cancer based on the molecular profile? So I first wanted to just bring out some ongoing trials that I think really do this well. So Rainbow, or Refining Adjuvant Therapy in Endometrial Cancer Based on Molecular Features, is a series of tiered phase 3 trials and a somewhat massive undertaking, to be honest. As you see, the molecular classification is kind of the first, and then stage is used to create this combination to triage patients into a series of differing phase 3 trials. So for those with POLE mutated tumors, this is a trial where adjuvant therapy will be de-escalated. There will be no adjuvant therapy for those with stage 1 or 2 disease, and then EBRT only for those with stage 3 disease. Conversely, in the poorest prognosis group, those with P53 abnormalities, they will be randomized to adjuvant chemoradiation followed by olaparib. I'll get to some PARP data in a moment, as compared to chemoradiation alone. And then mismatch repair deficient tumors will be randomized to external beam radiation plus immune checkpoint inhibition with durvalumab versus radiotherapy alone. And then, unfortunately, the NSMP subgroup doesn't have a clear targeted agent option, as we've kind of gone over. So this cohort represents an opportunity to better evaluate the role of hormonal progestin therapy. In terms, just to delve a little bit into the rationale for why PARP inhibition is of interest in endometrial cancer, the DNA repair capacity differs by molecular subgroup. Those with P53 mutations have some genomic homology to high-grade serous ovarian cancer, thus may have similar defects in single-strand or double-strand DNA break repair, indicating a potential role for PARP inhibition. Again, this molecular characterization tracks with serous histology. So while HRD rates may be similar, the rate of P53 mutation is much higher. To bring in some data, GOG012 is a trial seeking to kind of answer this question in a recurrent metastatic endometrial cancer subgroup, stratified not only on molecular subtype, but also on histology. Patients were randomized to cediranib, and anti-angiogenic versus olaparib versus cediranib plus olaparib. Patients must have had received one prior line of therapy, generally a platinum-based doublet, and prior biologic or immunotherapy was allowed. As you see here, the different treatment arms did not vary significantly in terms of progression-free survival, but the swimmer plot does, of serous patients alone, does demonstrate that there was a comparatively high number of responders and some with prolonged duration. And again, this is the cohort that would do very, very poorly. Potentially most importantly, molecular classification and analysis of these patients remains ongoing. A much smaller additional phase 2 study combined PARP inhibitor with immune checkpoint blockade. They demonstrated an objective response of about 16%, but did not meet the pre-specified endpoint of 50% progression-free survival at 6 months. In the responders, it's important to point out the very varied histologic distribution here. But teasing out the molecular subtype did not seem to clearly derive any particular benefit, but I think that the small groups really limit this analysis. As a last group to discuss, I do want to spend a little bit of time reviewing immunotherapy for endometrial cancer, as this has really been a game changer and changed the landscape of how we think about endometrial cancer treatment. As this audience is well aware, this obviously could be a talk all in itself. And I'm not a huge fan of the terms hot and cold tumors because I think the immune microenvironment is much more nuanced. However, for our purposes, the TCGA can make a clear distinction between based on the number of mutations between POLE and MSI subgroups. These tumors harbor kind of thousands of somatic mutations that encode potential neoantigens and lead to an immunogenic phenotype, as compared to copy number low and copy number high groups, which have significantly lower mutation rates. So in Keynote 158, this was a study, as you all are probably very well aware, including multiple different solid tumor types. However, a large proportion were endometrial. Nearly 60% of the enrolled patients have received 2 or more lines of therapy, representing a heavily pretreated cohort. However, they demonstrated significant response. So the objective response rate was 34%. For our purposes, the endometrial cancer cohort had an objective response rate of a whopping 57%. These findings led to FDA accelerated approval of pembrolizumab in 2017 as a monotherapy for patients with mismatch repair deficient or microsatellite unstable solid tumors. So I think that that really changed the game for the kind of use of immunotherapy. To show it in a different way and just pull out our kind of subset of interest, in the MSI high non-colorectal cancers, again, all with greater than 1 prior line of therapy, the objective response rate was 42, almost 43%, and a complete response was achieved in about 20% of patients. Thus, we can conclude not only does Pembro work, but it does so in pretreated patients and can have a prolonged duration of response. Multiple different endometrial cancer specific trials have replicated these findings. In Phaedra, using durvalumab, which was kind of the initial cohort of 35 patients, they demonstrated quite a similar response rate of 43%. And then in the subsequent larger Garnet study of dostarlimab, this was again in a previously treated recurrent advanced endometrial cancer with MMR deficiency. Again, the objective response rate was similar, about 45%. This led to the FDA approval of dostarlimab in that setting. And then notably throughout the trials, there has been a long duration of response. For about 93% of responders, that duration is greater than 6 months. That said, what do we do for patients who are not mismatch repair deficient, who are mismatch proficient. Did they have immunotherapy options? And the answer is obviously yes, in the combination of lenvatinib and pembrolizumab. So this regimen had been shown to have activity, including women with high-risk histology, such as serous. So this regimen was compared to chemotherapy in those who had received one prior line of platinum-based therapy and stratified by MMR status. So recently published, this phase 3 trial included over 800 patients and demonstrated that the progression-free survival for the total population was about 7 months versus about 4 months. And then in this kind of retained benefit in the MMR proficient subgroup. Similarly, overall survival was 18.3 versus 11.4 months. And 17.4 versus 12 months in the MMR proficient group. Again, we saw benefit in multiple histologic subtypes, including serous and clear cell. Thus, kind of while this regimen does require some careful monitoring and frequent dose modification to make it tolerable, and I'm happy to talk about that at length at the end, this combination has good activity in a recurrent endometrial cancer setting, including for those that are microsatellite stable. I just pulled out the Kaplan-Meier curves specifically so that you could see the all-comers and the proficient MMR subgroups. Again, you see the PFS benefit is preserved in the MMR proficient, and you see the OS benefit is, again, preserved even in the microsatellite stable or MMR proficient subgroups. And one other thing just to bring out here that I think is interesting is that the hazard ratios are actually pretty similar of 0.62 and 0.68. So lastly, I want to talk about some other targeted therapies for endometrial cancer that don't quite fit into those 4 molecular subgroups that we have been previously discussing. First, for those women with HER2 amplification, this is more likely to be expressed in high-grade endometrioid, grade 3, or in serous histology. They're much more likely to overexpress HER2. An initial phase 3 trial in recurrent endometrial cancer used trastuzumab weekly for HER2 positive patients and showed pretty disappointing results with a 0% response rate. Lapatinib was also attempted with a response rate of like 3.3% in an unselected patient population. And this led sort of to the kind of shelving of this agent and of these kinds of therapies for endometrial cancer. However, in 2018, a randomized phase 2 trial of carbotaxol compared to carbotaxol trastuzumab demonstrated significant benefit. So this trial had 61 patients, HER2 positive uterine serous cancer, and demonstrated that there was a clear progression-free survival benefit with a hazard ratio of 0.44, as seen in this curve on the left. When stratified by treatment setting, so you see advanced disease up at the top here and recurrent disease down below, it seems that the majority of the benefit was driven by these upfront stage 3 or 4 HER2 positive serous cancers. Again, the hazard ratio here of 0.4 and the hazard ratio in the recurrent setting much more disappointing of 0.14, non-significant. This data was recently updated. Again, it just demonstrates the clear benefit in overall survival at this kind of cutoff value of the addition of trastuzumab to chemotherapy in patients with HER2 positive uterine serous. Similar to the initial data I just showed you, again, the benefit was most profound in those with advanced stage tumors compared to those with recurrent disease. I did also want to touch briefly on selinexor, as it's obviously a very interesting agent and some of the newer data has just come out. This is a first-in-class selective inhibitor of nuclear export. At the most basic level, I won't get into the specific biology, but selinexor functions by binding with and inhibiting the nuclear export protein XPO1 that leads to the accumulation of tumor suppressor proteins within the cell nucleus. So in gynecologic oncology, there have been a few interesting studies worth noting. First, there was a phase 1 couple of years ago now, that was a mixed solid tumor. It did include both ovarian and cervix cancer, and demonstrated in the 6 gynecologic patients that there was significant clinical benefit. There were 2 partial responses and 4 stable disease. A subsequent phase 1 from last year that combined selinexor with carbotaxol included, it's a little bit heterogeneous because it had 4 different regimens at different dosings, 23 patients, 18 of whom had endometrial cancer, and demonstrated 12 partial responses and 1 complete response. In a heavily pretreated population and highly mixed between GYN cancer subtypes, as you see in this last trial, there was an overall reasonable disease control rate, about 30% in each cancer type. But I did want to bring out that there was a pretty disappointing median PFS of only about 2 to 3 months. However, the reason that I'm talking about selinexor is that SIENDO was just presented. So the SIENDO study was a prospective phase 3 of selinexor versus placebo as maintenance therapy after a response to platinum taxane doublet. They demonstrated a median progression-free survival of 5.7 versus 3.8 months. And then more importantly, I think, again, to go back to our molecular subtypes, in the subgroup of the NSMP, so P53 wild type microsatellite stable, the progression-free survival was actually not reached as compared to 3.7 months. Ongoing trials in this subgroup specifically will hopefully replicate these findings and provide, obviously, another addition to our adjuvant therapy toolbox. So I did want to just provide you guys with some summary, and then I'll have time for questions. So first, in summary, the molecular characterization of endometrial cancer is really here to stay. It helps us to better counsel our patients regarding prognosis, as well as hopefully better tailor our therapies. This is the NCCN recommendations here regarding the molecular analysis. So just to kind of re-summarize, the way that this PROMISE algorithm works is that first, POL-E sequencing is performed to pull out the about 5-ish% of patients who would be POL-E mutated. Those without a hotspot mutation then undergo mismatch repair protein immunohistochemistry. For those with expression lost, they are grouped in the mismatch repair deficient or microsatellite unstable MSI high subgroup. For those with retained expression on IHC of the mismatch repair, then P53 immunohistochemistry is performed. For those that are aberrant, they're in the copy number high, serous-like, or P53 abnormal subgroup with the poorest prognosis. And then for those in the P53 wild type pattern, they are in the copy number low, or the NSMP, no specific molecular profile subgroup. The no specific molecular profile and the MSI high represent intermediate prognostic groups. And as I mentioned, the copy number low, we really are trying to delve into some further stratification based on molecular subtyping, whether that is the CTNNB1 or the L1 CAM that tend to do worse within this intermediate risk group. And then again, POL-E does well kind of no matter what. As you see here, our European colleagues have actually incorporated these subgroups into their risk stratification and into their management guidelines. I think that this is sort of the early adoption of molecular profiling and molecular characterization. Again, I'm not going to go through this very complex table, but the risk grouping depends certainly on stage, but also on these molecular classifications. So for the unknown group, the staging and the pathologic classification as we kind of classically did. And then for the molecular classified group, we can be a little bit more nuanced in our recommendations. That said, I do want to conclude with the areas that I think remain in question and in need of further study. So specifically, while we know that molecular subgroups are prognostic and are certainly predictive, what exactly should our routine testing entail? Certainly MMR status and methylation testing is now performed relatively universally, but should we be doing POL-E mutation for all? This would require next-gen sequencing for all endometrial cancers. And then P53 is probably a little bit lower hanging fruit. That's an immunohistochemistry test. Should we be doing P53 testing for all endometrial cancers? Second, I do think it's important to better refine these subgroups. As I just mentioned, the NSMP subgroup can be further stratified based on additional mutations such as Wnt or L1CAM. And then how do we incorporate these into our ongoing trials and our treatment planning? Does routine testing include those as well? Lastly, as I have kind of gone over at length today, there are multiple ongoing trials that will really hopefully change the landscape of how we consider adjuvant therapy for endometrial cancer. Whether that is the NRG trials that I briefly reviewed for you all with early endometrial cancer and that high intermediate subgroup, or such as like the rainbow or taper trials, and in the advanced subgroup, can we better use chemotherapy and the systemic agents for advanced endometrial, as well as some of the novel agents, whether that is not so novel anymore, immunotherapy and immunotherapy combination strategies, or whether that is novel agents such as selinexor. The addition of lenvatinib and pembro for the mismatch repair proficient group really changed how we treat endometrial cancer, and is moving earlier and earlier in our treatment paradigm, being compared to carbotaxol. So will that become kind of our first line for endometrial cancer? Lastly, I would just like to leave with the emphasis that molecularly driven trials are the way forward. I think I'm sort of preaching to the choir with this audience, but I really feel they have the potential to provide the optimal tailored therapy for our patients. So that is it. I will stop sharing my screen, and I am happy to answer any questions that you might have and give you back 10 to 15 minutes of your morning, if not.
Thank you, Emily. That was great. That was very helpful. I don't see any questions in the chat box, but I do have a question, and I apologize if you talked about it and I just missed it. When you have the poly mutation patients, I know it sounds like it's not currently standard sort of across the board to test for it, but when you do test for it and you have a poly mutation, sort of do you go to immunotherapy, or do you sort of still start with systemic therapy with chemo and then kind of think about immunotherapy down the line?
It's a really good question. I think that the trials are ongoing. I will say that many of the trials, the recurrence rates for POLE are so low that many of the trials are actually backing off on any adjuvant therapy, especially for kind of the intermediate risk. One of the trials is even stage 3, doing just radiation rather than radiation plus chemo. I agree with you. I think there is a role for immunotherapy here, certainly, and moving that into the kind of front line for high risk disease, advanced stage, and at recurrence, though specific trials in POLE mutations are hard to run because it is only 5% of the cohort. But I do think it's relevant, and I do think that many are considering immunotherapy frontline for them.
It's at least tempting to think about it, right?
Exactly. I think the trials aren't there yet. It is very tempting to think about. And certainly if immunotherapy moves frontline in mismatch repair, we will by proxy use that for POLE mutation.
That's great. And I think that's sort of what we think about when we see it in GI cancers anyway, is you're tempted to use it more than anything.
Right, exactly.
I don't know if anybody else has any questions. Give it a minute or so.
Sure.
There is a question in the chat box. So it's from Jenna Marcus, I think is what it is. Do you think there will be a role for maintenance therapy in high-risk groups?
Yeah, so I think that's a really good question and speaks to kind of the nuances of these targeted therapies, whether that maintenance is something like selinexor for that intermediate group P53 wild type, or whether that maintenance becomes something almost like an ovarian cancer model with olaparib or the anti-angiogenics. I think that's coming down the pipeline. I think we're not quite there yet.
I don't think we have any more questions. Oh, nope, I lied. There's one more. There's a question about, is HER2 testing routinely done for serous endometrial cancer?
So it should be. I think that has made its way into kind of the standard of care, especially given the strength of the trastuzumab data. And so uterine serous generally gets HER2 testing following a pathologic diagnosis. Again, the trastuzumab data right now is limited to the advanced stage 3 and stage 4, and then obviously in the recurrent setting. But the benefit is in advanced stage, or the real benefit is in advanced stage. So that's really where it matters.
And I guess, I mean, just to kind of go off of that, is that then in the advanced metastatic space, is that sort of standard of care across the board that it's done no matter what?
I think that most of us have adopted that data. It's pretty, the addition of trastuzumab to carbotaxol is what we do for HER2 positive. Again, obviously, if there's equivocal, FISH amplified, making sure that you're selecting your patients appropriately, but I would say that is standard of care.
Great. We might stop there, and thank you very much, Dr. Hinchcliff. We really appreciate it. That was great.
Of course. Thank you so much for the opportunity.
Thank you.
Thanks, everyone. Have a good day.